So up until now, measuring MRD really did not affect decisions. So for example, we knew we could get MRD negativity in a subset of patients who got chemotherapy, particularly with FCR, after 6 cycles. The issue was if the patient was MRD positive, and by the way, if they're MRD negative, they do have much longer progression-free survival as expected. But if they're positive, the question then would become, well, what do you do? And so there was no consistent strategy for what to do in that setting. So it was information that was predictive. It could tell you, who would have a longer or shorter PFS, but there was no decision-making necessary. Now there's a lot of focus on that with venetoclax because we have a couple of trials, particularly the ones combining venetoclax with antibody, suggesting high MRD negativity rates with venetoclax. And this is in contrast to ibrutinib, where you don't really see MRD negativity. The potential advantage of that, and that has been actually carried out in the 2 registration trials, well, one that expanded the label in relapse, and that was the Murano trial, where now venetoclax and rituximab is an approved combination, and the German CLL14 trial, which we just heard about, that has now expanded the label to frontline patients getting venetoclax and obinutuzumab. Both those trials showed high MRD negativity rates, and both were designed to stop therapy. So in other words, in the Murano trial in the relapse patients, everybody stops at 2 years. In the frontline trial, it was 1 year. So this is very different because the way venetoclax was originally approved, the way all of the small molecule therapies that we have, the B-cell receptor inhibitors have been approved, is continuous until progression. And that can be daunting to a patient if they think they're going to have to be on a drug for years and years and years, indefinitely. So one of the nice things about the fact that the MRD negativity rates were high is the thought that we can stop therapy and then these MRD negative remissions are going to be very durable. It obviously raises the question, well, should we be basing it on a finite time or should we try and treat MRD negativity? And that's an interesting question. When the Murano data was actually presented at ASH the year before, John Seymour was the presenter, and someone in the audience asked him that. They said, well, it looks like the people who are MRD positive at the end of 2 years and stop are the ones who, not surprisingly, most quickly relapse. Should we be treating them longer? And his answer was interesting. He said, I don't think so, because when we look at those patients who were still MRD positive at the end of 2 years, and we look at their values that were obtained along that 2-year spectrum, they had either plateaued or in some cases were going up. So his argument was he thinks they had some inherent resistance. It's very interesting because if you look at who those people were, they were very markedly enhanced for 17p deletion and p53 mutation, so even with small molecules, that continues to be a high-risk group. But there's a lot of excitement, I think, around the fact that you can achieve these deep remissions, and that might enable you to stop therapy.